Good day. I will present adrenal insufficiency. The adrenal gland synthesizes steroid hormones in the cortex, which include glucocorticoids represented by cortisol, produced in the zona fasciculata, mineralocorticoids represented by aldosterone in the zona glomerulosa, and gonadocorticoids represented by sex hormones in the zona reticularis. Catecholamines are produced in the medulla. These include norepinephrine, epinephrine, and a small amount of dopamine in response to stimulation by sympathetic preganglionic neurons. Adrenal insufficiency is deficiency of adrenal gland hormone production in the cortex. Primary adrenal insufficiency or Addison's disease is due to intrinsic adrenal gland dysfunction and results in decreased cortisol, aldosterone, and sex hormone production. Secondary adrenal insufficiency is due to hypothalamic pituitary dysfunction with failure to secrete corticotropin-releasing hormone and/or adrenocorticotropic hormone. This results in cortisol deficiency only. Meanwhile, adrenal crisis is a life-threatening exacerbation of adrenal insufficiency when an increased demand fails to increase hormone production. Cortisol is secreted in response to direct stimulation by adrenocorticotropic hormone. ACTH secretion is stimulated by corticotropin releasing factor released from the hypothalamus. Secretion occurs in a diurnal rhythm, with higher levels secreted in the morning and lower levels in the evening. In normal circumstances, the daily cortisol equivalent is about 20 milligrams per day of hydrocortisone. Plasma cortisol suppresses the release of adrenocorticotropic hormone through negative feedback inhibition. Cortisol facilitates the stress response by affecting the heart, vascular bed, water excretion, electrolyte balance, potentiation of catecholamine action, and control of water distribution. It affects fat, protein, and carbohydrate metabolism by stimulating glycogenolysis and neoglycogenesis. It is involved in immunologic and inflammatory responses and affects calcium metabolism. It promotes growth and development, but in excess, interferes with the gastrointestinal tract mucosa maintenance, leading to peptic ulcer. Aldosterone secretion is controlled primarily by the renin-angiotensin system and serum potassium concentration. The renin-angiotensin system controls aldosterone levels in response to changes in volume, posture, and sodium intake. Hyperkalemia influences the adrenal cortex directly to increase aldosterone secretion. Aldosterone maintains sodium and potassium plasma concentrations. It regulates extracellular volume and controls sodium and water balance. Gonadocorticoids include androgen hormones and estrogen. Androgens produced include testosterone, dihydroepiandrosterone, and dihydroepiandrosterone sulfate, which are present in both men and women. In women, androgens are produced in the adrenal glands as well as the ovaries and promote the development of sex characteristics such as axillary and pubic hair and libido. In men, most androgens, especially testosterone, are produced in the testes. Androgens made by the adrenal glands are less important for normal sexual function. When it comes to causes of primary adrenal insufficiency, these include autoimmune, adrenal hemorrhage or thrombosis, drugs, infections, infiltrative disorders, surgery, and hereditary. For autoimmune disorders, these may include isolated adrenal insufficiency or associated with polyglandular insufficiencies, such as polyglandular autoimmune syndrome type 1 or 2. Adrenal hemorrhage or thrombosis can be due to necrosis caused by meningococcal sepsis, coagulation disorders, or overwhelming sepsis in the setting of Waterhouse-Friderichsen syndrome. Drugs, especially adrenal enzyme inhibitors, which affect those with a limited pituitary or adrenal reserve, include etomidate, aminoglutetimide, which can be used by bodybuilders, mitotane, which is an orphan drug used to treat adrenocortical carcinoma, and ketoconazole. Infections that may affect the adrenal glands include tuberculosis, fungal and bacterial sepsis, and acquired immunodeficiency syndrome involving the adrenal glands. Infiltrative disorders of the adrenal gland include sarcoidosis, hemochromatosis, amyloidosis, lymphoma, and metastatic cancer. Surgeries that may cause primary adrenal insufficiency include bilateral adrenalectomy and bariatric surgery. and hereditary causes include adrenal hypoplasia, congenital adrenal hyperplasia, adrenal leukodystrophy, and familial glucocorticoid deficiency. Approximately 90% of the adrenal gland must be destroyed for clinical adrenal insufficiency to develop. Polyglandular autoimmune syndrome type 1 is associated with candidiasis, hypoparathyroidism, and adrenal failure. Polyglandular autoimmune syndrome type 2, on the other hand, consists of Addison's disease plus either an autoimmune thyroid disease or type 1 diabetes mellitus associated with hypogonadism, pernicious anemia, celiac disease, or primary biliary cirrhosis. Human immunodeficiency virus may cause adrenal insufficiency through opportunistic infection with cytomegalovirus, and use of medications such as ketoconazole may also contribute to this. Secondary adrenal insufficiency can develop through inhibition of the hypothalamus pituitary adrenal axis. This includes sudden cessation of prolonged glucocorticoid therapy, which is due to chronic use of steroids because this inhibits CRH and ACTH production, pituitary necrosis or bleeding due to postpartum pituitary necrosis or Sheehan syndrome, exogenous glucocorticoid administration, which causes decreased production of CRH at the hypothalamus and ACTH at the pituitary, brain tumors such as pituitary tumors, hypothalamic tumors, or local invasion through craniopharyngiomas, pituitary irradiation, surgery, and head trauma involving the pituitary gland disrupts corticotropin releasing hormone and ACTH production capacity in the hypothalamic pituitary axis. Infiltrative disorders of the pituitary or hypothalamus include sarcoidosis, hemosiderosis, hemochromatosis, histiocytosis X, metastatic cancer, and lymphoma. And CNS infections involving the hypothalamus or pituitary include tuberculosis, meningitis, fungus, and human immunodeficiency virus. The most common cause among these is long-term therapy with pharmacologic doses of glucocorticoids. Severity of adrenal suppression is variable and depends on the dose and potency of the glucocorticoid and the time of day the drug was taken. Suppression is usually greater when taken in the evening. Recovery of the hypothalamus pituitary adrenal axis may take a few months to 1 year after steroid cessation. Although this suppression is related to the duration of treatment, steroid dose, and total cumulative dose, there is no strict correlation with any of these factors. Adrenal crisis is shock refractory to volume resuscitation and pressors. It can result from acute destruction of the hypothalamic pituitary axis or the adrenal glands, or from acute stressors in the setting of underlying primary or secondary adrenal insufficiency. Reported stressors include acute infection, especially gastrointestinal infection, surgery, extreme physical activity, acute severe injury or burns, and cessation of chronic glucocorticoid replacement. Primary and secondary adrenal insufficiency have different clinical presentations. Volume depletion and hypotension is marked in primary adrenal insufficiency, and in secondary, it's not as severe unless crisis is present. Serum potassium is elevated in primary adrenal insufficiency due to issues with aldosterone, whereas in secondary, hypokalemia may occur due to only cortisol being affected. Serum sodium is usually hyponatremic in primary adrenal insufficiency due to salt wasting, whereas in secondary adrenal insufficiency, it could be hypernatremic due to aldosterone functioning or hyponatremic due to water retention. Cushing white appearance is only present in secondary adrenal insufficiency, especially if it's due to long-term glucocorticoid use. Symptoms of other pulmonary, or rather pituitary hormone deficiency, such as hypothyroidism and amenorrhea, may be present in secondary adrenal insufficiency depending on the site of the hypothalamic pituitary cytopletion. Skin pigmentation, on the other hand, is present in primary adrenal insufficiency due to high ACTH levels, which stimulates hyperpigmentation. As mentioned, the acute adrenal crisis is characterized by severe hypotension refractory to vasopressors. Other symptoms include severe abdominal pain, nausea, and vomiting, mimicking an acute abdomen. CNS symptoms of confusion, disorientation, and lethargy may be present. There may be associated sepsis even without fever. We consider adrenal crisis in situations of unexplained hypotension, especially in patients with a history of glucocorticoid therapy, those with acquired immunodeficiency syndrome, tuberculosis, autoimmune disease, or severe head trauma, those with a history of chronic fatigue and hyperpigmentation, and those with disorders known to cause acute adrenal crisis. Laboratory studies we usually get are bedside glucose determinations to identify hypoglycemia, CBC, full chemistries, hepatic function studies, EKG, and urinalysis for differentials. If there are other underlying sources such as sepsis, hemorrhage, or CNS abnormality, we may request additional studies. As mentioned, primary adrenal insufficiency is characterized by hyponatremia and hyperkalemia due to aldosterone deficiency. Secondary adrenal insufficiency may have hypernatremia, again from functioning aldosterone causing sodium reabsorption in the kidney, or hyponatremia following water retention and hypokalemia. In both primary and secondary adrenal insufficiency, cortisol deficiency is common, and hypotension or hypoglycemia may be present. Mild metabolic acidosis is evident due to tissue hypoxia from hypovolemia and hypotension. EKG changes are generally related to potassium imbalances such as prolonged QT, peak T waves, and heart block in hyperkalemia in primary adrenal insufficiency, or inverted T waves and presence of U wave in hypokalemia in secondary adrenal insufficiency. An abdominal CT scan can identify adrenal gland hemorrhage or infarction. When serum cortisol determination is available, if it's more than 18 micrograms per deciliter, it generally rules out adrenal insufficiency. The adrenocorticotropic hormone stimulation test measures serum cortisol after stimulation by synthetic adrenocorticotropic hormone or cosyntropin. Serum cortisol rises significantly in secondary but not in primary insufficiency. Adrenocorticotropic hormone level measurement also helps differentiate between primary and secondary adrenal insufficiency. It's high in primary adrenal insufficiency and low in secondary adrenal insufficiency. When treating primary insufficiency, it requires daily dosing of glucocorticoids and mineralocorticoids, usually for life. Usually, hydrocortisone is given because it has both glucocorticoid and mineralocorticoid effects. Mineralocorticoids are replaced with an oral synthetic mineralocorticoid drug such as fludrocortisone. For secondary insufficiency, only glucocorticoid replacement is required. The recommended treatment for adrenal crisis is as follows. We administer IV fluids for hypotension and use dextrose-containing saline if hypoglycemic. We give steroids, hydrocortisone, at a 100 milligram bolus being the drug of choice for cases of adrenal crisis or insufficiency, especially with underlying primary insufficiency, or dexamethasone at a 4 milligram bolus, which is preferred if rapid adrenocorticotropic hormone stimulation test is complicated or contemplated. We consider vasopressors and administer them only after steroid therapy in patients unresponsive to aggressive fluid resuscitation. You can choose norepinephrine, dopamine, or phenylephrine. We also consider supplementation with steroids for patients who may require lifelong glucocorticoids, mineralocorticoids, and/or androgen supplementation. We also determine the underlying cause and investigate as appropriate because the patient might have sepsis, adrenal hemorrhage, or CNS abnormalities. Then we optimize the maintenance dose of steroids. During periods of stress, we increase maintenance doses of chronic steroids to 3 times the daily dose to satisfy increased physiologic need for cortisol. So when it comes to patients on chronic corticosteroids, we always consider adrenal insufficiency in patients with chronic steroid use presenting with any acute illness. The HPA axis function should recover within about 1 month from the last dose of steroid intake, but may be longer in some cases. If the patient is receiving steroids through topical, intranasal, inhalational, or per rectum routes, then hypothalamus pituitary adrenal axis suppression is not a risk. For patients with chronic adrenal insufficiency with acute illness or injury, we usually triple the daily glucocorticoid dose for 24 to 48 hours following a minor illness or injury. And for patients who are pregnant and have adrenal insufficiency, they may need to take medications on schedule with close monitoring of the mother and fetus. They are able to undergo healthy pregnancy, labor, and delivery, but they may require adjustment of glucocorticoid doses, especially during the third trimester and during labor. Women with hyperemesis gravidarum may need to switch from oral medication to parenteral medications until symptoms subside.